Hello, hello. I want to give everyone a few minutes to join and we will get started. So as you guys log in and join today, welcome to today's Live with Liz. Please put some comments and questions in the right sidebar where you see the opportunity to post. Let me know who you are, where you guys are joining from, and any questions you might have in advance. As you know, Live with Liz is something that I've always done with the Peace of Mind Foundation. I do it twice a month, the second and fourth Wednesday of every month. And now, of course, I'm doing it on behalf of the International OCD Foundation. About a month ago, we announced that Peace of Mind has officially become a part of IOCDF. And so we're excited to be able to merge forces and help more people. So you will now see me here. So we're doing it through StreamYard versus Facebook Live. So for those of you who got used to Facebook Live, I want to give you some time to transition over. And of course, this platform, I think, is actually much more interactive and works a little bit better. And then, of course, as always, we'll post these afterwards. So if you miss any live events, you can see them later for sure. Hi, Michael. Great to see you. Thank you so much for joining. So let's hop into a few things. So the way Live with Liz works is what I like to do is answer questions live, as always, hence the Live with Liz, but also pre-submitted questions. So if you have any questions you want to submit in advance of my live events, you can email them to info@iocdf.org. You can keep these anonymous. You can ask specific questions, whatever you want. Just know that if you post questions in the comment bar, your name does show up, so confidentiality can be compromised. And same if you give specific or detailed information in the questions that you submit in advance. I will always try my best to answer all the pre-submitted questions, the ones that I can appropriately at least, and then the live ones as well. This is not treatment. It's not intended to replace treatment. So I will do my best to answer all your questions, but in a way that is more general and really education-based versus treatment-specific based. As always, if you're in crisis, you're feeling unsafe or suicidal, please call 911, call your national suicide hotline, depending on where you live, or visit the local emergency room. We always post the suicide hotline, but I know not everybody's from the US, so this is our number for here in the US. You would want to check out your own emergency services. So let's hop in. Please submit questions as you go. I have a lot of pre-submitted questions, so we're going to start with those, and then we'll make our way over. It is November 11th, so happy Veterans Day to all those who have served in the United States. We celebrate Veterans Day, and I want to personally send my gratitude and appreciation for your service, which allows us to live freely the way that we do in our country. It's also 2 weeks now, which is crazy, until Thanksgiving, and I think that the holidays are a time for those of us with anxiety and OCD that can be triggering. They can be anxiety provoking, whether it's contamination based because we're around family and friends, we're eating together, whether it's, just general anxiety because we've maybe avoided some of these people, or social situations can be anxiety provoking. And so I want to make sure that I always leave space and room during November and December for us to bring up holiday concerns, also holiday blues, and some of the things that many of us experience around this time of year. So let's jump into some of the questions. First question for today is, do you have advice for teens talking to the parents about their OCD, especially when you're experiencing sexual intrusive thoughts? This is a wonderful question and a really important one, because I think that, many times when we live with OCD, we feel comfortable talking about certain subtypes that we feel like aren't as taboo or maybe are more well-known, right? Maybe we think of like contamination OCD or checking OCD, where people can understand, or when they think of OCD, they think of someone checking their stove over and over, or their lock, or engaging in excessive hand washing. But maybe things like sexual intrusive thoughts, or even scrupulosity OCD or harm OCD, these are some of the ones that we don't talk as much about, and that there's not as much general education. And so somebody who doesn't have OCD and it's more foreign to them, like a family member, a parent, an adult, a grandparent, whoever it might be that you're sharing, there might be some anxiety around, gosh, what are they going to think if I talk to them about this subtype of OCD? This subtype is very triggering. This subtype is very anxiety provoking for me, and these thoughts scare me to death. And so what if when I tell them, they think these thoughts are real? They think this is who I actually am. What if they don't understand them? What if the way they respond triggers me more? And so what I would say is that I think we should, I'm a big person that we have to break the stigma. We need to talk openly. We need to share our intrusive thoughts. but I think we have to do it in a way that's going to be most receptive to people who don't understand it. And so what I would say is start with general OCD education. Start by talking a little bit about just kind of the main components, right? Like I'm living with OCD, I'm having these unwanted intrusive thoughts, I'm engaging in these repetitive rituals. And sometimes they might say, well, what are some examples? Tell me about that. That's when you get to choose the level of the example you're going to share. Ethan Smith and I talk a lot about this, that, on a first date, you're not going to share your most intimate, scary, triggering OCD thoughts, but maybe after 2 years of dating someone, you're comfortable sharing those things. I think it's the same even with parents who you trust, right? You're going to give them a little bit of education around OCD and then allow them to ask more when they're in the headspace to appropriately absorb it. And so one of the things I say is that education can be a really helpful tool, especially when they're learning about certain subtypes of OCD, but it doesn't necessarily come directly from you, right? A parent hearing about our scary intrusive thoughts can also be scary for them. They might want to fix it. They might really struggle with, oh my gosh, you're struggling so much with that. That has to be so hard. And that might be a hard place or thing for them to feel like they have to hold on to. And so what I say is that send them to IOCDF, send them to peaceofmind.com, have them watch some of the videos on subtypes, ask them to watch some of the videos on sexual intrusive thoughts, to hear from other people who've had intrusive thoughts around this subtype, so that then you might be more comfortable sharing more because they've had some basic education. I also would highly recommend, when we're trying to educate people we love about our OCD subtypes, bringing them into a therapy session. Allow them to join a session where you can have your therapist kind of be the moderator, but be the individual who helps explain these in more detail, who helps you better understand, helps them better understand your subtype, and to where they can ask questions. And sometimes they feel less anxious if they're asking that question to a third party who has a background and specializes in OCD compared to asking you, because they might not know the right questions to ask, or they might be anxious about it. So I think talk to your parents about it slowly introduce, provide education with appropriate content, right? Resources and foundations that you trust and that have good content in these subtypes and areas, and bring them into therapy with you so that a therapist can help navigate these conversations in an appropriate and helpful way. The next question submitted is, what is an IOP program? And this is a great question, and I think something that really Chelsea and those at IOCDF, I think we should consider doing one of my lunch and learns, which, just so you guys know, we're roughly doing events now every week. And so I will do Live with Liz every other week. And then on other weeks, I'm doing kind of a lunch and learn series where I'm really bringing professionals and talking about content. But I think it'd be really great for us to do one on levels of care, and to have experts who run different programs talk about how different levels of care work for OCD. So as many of you know, I'm the director here at the McLean OCD Institute in Houston, and we have multiple levels of care. So we have really intensive, which is our residential support program, and a partial hospitalization program. We've offered intensive outpatient programs, which is the IOP, and then of course outpatient services, and they look very different. So when you think about levels of care, really what you think about is severity and needs, right? Depending on how much I'm struggling, how much my OCD is interfering with my life and causing disability, that's going to impact the level of care that I need. If I am totally occupied with OCD, and OCD, impacts everything I do, I'm no longer working, I'm totally disabled, traditional outpatient therapy, which is usually about once a week, a 45-minute session, may not be the best fit for me, right? I might need more. I might need something more intensive. And so an IOP is a step up from outpatient. It's called Intensive Outpatient Program. And traditionally, an IOP is about 3 to 5 days a week, roughly 3 hours a day. So sometimes these programs will be Monday, Wednesday, Friday from 3 to 6 p.m. Sometimes they're daily, 3 hours a day, but that's roughly an IOP. But the point is that it's an intensive outpatient program. So you would commute, you would do it on an outpatient basis, but it's more intensive than a traditional once a week, 45-minute session. PHP, which is the partial hospitalization program, and then the next level up from that is residential programs or residential support programs like we have here. They're programs where it is even more intensive. So often a PHP is more like 4 to 8 hours a day. So like our traditional programming here in Houston runs from 8:45 in the morning until 4 p.m. And then on weekends, it's usually about 9 a.m. until 2 or 3 p.m. 9 a.m. until 3 p.m. or sometimes 4 p.m. depending on the weekend day and what we're offering. And then you have support otherwise as well. So our patients who live in our residential support program, they would get support 24 hours a day from on-site kind of what we call residential counselors, so individuals who are trained in how to support and provide appropriate support outside of the treatment day. And so these are the levels of care. And so really, if you're seeing an OCD specialist, even on an outpatient basis, they should be able to determine what level of care they would recommend for you. So depending on your severity, depending on your diagnosis, they might recommend a residential program, a residential support program. They might recommend an IOP. What I will say is that programming has shifted a little bit because of COVID. So while programs like ours, McLean in Boston, Rogers, Neurobehavioral Institute, some of them have been able to resume or keep their residential programs open. A lot of, if not actually all that I know of, the IOPs and day programs have gone virtual. And a lot of patients, if you don't live in Texas, for example, you can't do our virtual programming. And so if you're traveling here, you might do residential support, even if you traditionally, maybe you could have been able to do our PHP day program, just because you want to be in person and the programming looks a little bit different. And so right now, a lot of those intensive programs are online, which can also be an amazing benefit because many of us, as you know, right, our OCD is worse sometimes at home and in those home situations or environments, and we're able to appropriately address and treat these issues when we're in the home, which can be really nice and a useful addition. So there's multiple levels of care. And what I'm going to do is make sure we add to our agenda doing a lunch and learn where we're going to bring on people who specialize in each level of care and where we're really going to talk about the different levels, what to expect, what it looks like, what these programs are, how we specialize in OCD, and how to kind of know what the trajectory of treatment would look like depending on the level of care that you might consider for your diagnosis. Relationship OCD. Could a past bad relationship fuel my OCD in a new relationship? I'm constantly fearing and doubting that my partner might cheat on me. I think the answer to this is absolutely, right? What we know is that OCD can latch onto anything, and oftentimes past experiences or situations can cause new triggers, can cause new intrusive thoughts. What I'll also say, though, is sometimes if we have a past experience and then it's contributing to a current relationship or to current things that are going on because there's reminders of the past or triggers from the past, we can't identify everything as OCD. So I think it'd be really important that you work with a specialist to be able to tease apart, like, what is OCD and what is kind of fueled by past experiences and triggers that I might need to work through that could be different than OCD, right? It's really important to understand not every time we feel anxious or uncomfortable that it's OCD. So it could be, it could not be, but certainly sometimes, certain situations can then increase OCD symptoms as well. So I think it depends. What are some of the tips for parents who are struggling with accommodating and reinforcing their child's OCD? What's the best way to handle the anger your teen experiences when you refuse to help or accommodate? This is a really good and important and critical question, and I think the answer, I certainly don't think we'll be able to answer all of it. I would certainly like us to do a lunch and learn as well, Chelsea, if we can plan on this in the future, that's really focused on accommodations and bringing on not just a child OCD specialist, but also bringing on a parent to talk about how hard it is and how you hold those lines and how you hold those boundaries. I think one of the things that's really important is it depends on the level of accommodation and the age of the child, right? If we are accommodating for a 24-year-old adult with OCD, the way we would start to reduce accommodations and set appropriate boundaries is very different than a 10-year-old, right? Maybe the 10-year-old, you still have to prepare their meals because they don't know how to use an oven on their own. I don't know when you start to use an oven. I don't have any children, but for a 24-year-old adult, you can have different expectations. So I think age, of course, is dependent. I think my biggest go-to is I really want you working with their provider. So I think that any provider who is treating a child with OCD, if you are not actively involved in that treatment, that should raise some concerns, and you should be asking how come. It would be really an injustice, like disservice is the right word, for us to be treating a child with OCD and not bringing the parent into the therapy in some manner, right? We can't just expect parents, hey, just stop enabling and not give you direction on how to do that and what that'll look like. we wouldn't recommend that enabling is just cut off overnight, right? Because I think that is often when you'll see the anger and the explosive nature and the difficulty of the child being able to manage that sudden shift or change in your reactions or your response to their OCD. But I think that when you work together with a provider and you come up with a plan that the child is a part of and they're aware of, it's really important that you work to hold that line. I think as far as how we respond, right? When we are used to getting our OCD answered quickly, right? We have a trigger and we're used to it being accommodated or it being addressed and us feeling relief. When there's a shift in that, even though that shift of no longer enabling, it's for the better, it's what we need long term, it's hard, right? It's different. It's a new experience. It's a new situation that we have to learn to manage. And so I think, again, that's an important piece where it's okay as a parent to have very clear boundaries of like, I know this is going to be hard for you. And I know that you might, need some outlets when we say no. And here's some healthy ways I'm willing to work with you. When you're feeling frustrated, like I'm happy to go on a walk with you. I'm happy for us to engage in this activity together that's enjoyable, but it's not acceptable in the household for you to slam doors, for you to use foul language, right? You can still hold boundaries with that child, right? That's a job as a parent. Like that's something that you have to do. You can't just say, oh, well, they're upset and it's their OCD, so it's okay, right? Because you have to set some boundaries that are important for your household, especially if you have other children and you can't let one child and their OCD be controlling, right, the household and the reactions, because then the other children will think it's okay for them to do the same thing. And so I think, again, I really want you to work together with a provider, but also talk to the child about, and the provider about, what are emotion regulation skills that this individual child can start to use and can start to try, and how can I help encourage them to use those skills and tools when they're feeling dysregulated, right? If we start saying no and we start no longer enabling behaviors we used to enable, it is going to be hard and we're going to feel really emotionally dysregulated. And if we don't have skills to manage that, it turns into fighting, it turns into blowing up, it turns into anger. And so focus a little bit on what are some of those skills and how can I support my child in using those skills versus not. Second question is, I'm a special education teacher, and what are some ways I can help support my students with OCD? I think that the answer to this, first of all, thank you for asking the question. The fact that you are an educator and you want to know how to support shows how much you care and how important it is to you. I'll say for me, one of the best things that happened is I had a teacher who asked my mom specifically, how can we help Liz? We don't want to enable her, but how can we help her? And my mom was able to provide some educational resources. I remember she gave them kissing doorknobs and a small OCD education book. And those teachers read that book and they gained some basic, really valuable education on OCD. And I think that was the first most important thing. So just having basic information, right? Visiting peaceofmind.com, visiting iocdf.org, gathering information, maybe doing our anxiety in the classroom training, right? Learning how to best support and also the basics of what does OCD look like? What does anxiety look like? And then it's going to be about working with the parents and working with the provider, right? Sometimes accommodating can be enabling. Right? When I was in school, I remember I'd get really stuck. And so sometimes I'd be late for class or different things. I didn't just have a free pass to be late anytime and have no penalties, right? We came up with a good plan of how often do you feel like you would need a tardy? How often do you feel like you would need to be late? And so I think that it's really important for you to also work with the provider and to know what the expectations are. When a child's in treatment, right, the level of support and accommodations they would get before they're in treatment should look very different and be a lot more than the level they're going to get when they're terminating treatment. And so it's important as a teacher that you're also in the know so that you can support that appropriately. Scrupulosity. How important is it to find an OCD specialist that is of your same religion? I fear that if they're not of the same faith background, they won't understand my OCD fears or make me do something that goes against my beliefs. This is a phenomenal question, one that I get all the time and one that I have personal experience with. I actually was treated by a provider who wasn't of the same faith background as me, yet I had amazing success. And so here's what I want to say. I get it. Right? I think that our biggest fear with scrupulosity is that you're going to change my faith. You're going to change our faith relationship. You're going to try to make me less faithful. And I think what's really critical is for us to understand that a provider who knows how to treat OCD and is an OCD specialist can treat any subtype of OCD. They don't need to have experienced harm OCD to be able to treat harm OCD. They don't need to be of your same faith to be able to treat scrupulosity. But what it is their job to do is to understand your faith if it's something that that they don't practice themselves, right? It would be really important that they understand what is normal faith practice when it comes to these behaviors, and where could you identify, or would your faith leaders identify that this is OCD? And usually we're able to really clearly tease it apart, right? This is normal faith practice versus this is above and beyond. People who are very spiritual, even of my faith, wouldn't say this is of the norm. Like, they would say that this is more kind of irrational or anxiety or OCD driven. And so what I want to say is that it's our job when we treat scrupulosity. It is not our job to make you less faithful. It is our job to remove OCD from your faith relationship so that you can have a healthy, functioning relationship with your faith that isn't controlled by OCD. I hear this a lot in general, right? Do I need to go to an OCD practitioner who treats OCD, who lives with OCD, right? A lot of people actually will say this to me. It's like, well, Liz, I want to see you because you understand what it's like to have OCD. And my response is that, well, sure, yeah, I live with OCD. We know that. I'm open about that. You don't need to have somebody who lives with OCD treat your OCD. You need to have somebody who specializes in OCD, right? That is the critical piece, whether it's scrupulosity or whatever subtype. You have to be with an OCD specialist. And I would venture to say it is much more important that you're with an OCD specialist than someone who has the same background as you. Somebody who has the same faith background as you but doesn't understand OCD isn't going to be able to treat your scrupulosity. And so while sometimes, sure, it may be very valuable if they understand your faith or they have the same faith background, it's really important. In fact, more important, I think, for OCD, that they have OCD specialty and OCD background. I always say, if I had cancer, right, my oncologist doesn't need to have had cancer. He doesn't need to have had the same experience, but he needs to have the education and background to treat my cancer and to treat my diagnosis. And I think it's the same with OCD. How does OCD differ in children compared to adults? Is there a different approach to treatment that involves parental involvement or other methods to modify ERP that caters to children? I'm curious if the age influences the symptomology of OCD. These are two questions that are really good, so I'll answer them in two parts. So the first part is, does OCD look very different? And the answer is not really, right? Symptomology, children with OCD, when I was young, I had, you name it, as far as OCD symptoms, whether it was scrupulosity, sexual intrusive thoughts, harm intrusive thoughts. And sure, as an adult, maybe some of my intrusive thoughts are different, but as far as the symptomology and presentation, at a young age, you can have all spectrums of OCD, all subtypes, and as an adult, you can have all subtypes. The treatment does differ for a couple different reasons, right? The treatment itself stays the same. The components of ERP doesn't change, but the language that we use does, right? The language that I'm going to use when I'm talking about habituation and exposures and hierarchy development with someone who's in their 20s is very different than an emotion regulation, right? Is very different than a child who's 10 years old, where I'm going to talk maybe about a fear ladder and I might use like red, green, and yellow versus SUD scores, or I might, right? So the way we address it and the language that we use would be child specific. Parental involvement is drastically different when we're treating a child with OCD than an adult with OCD, right? A 20-year-old, 22-year-old who lives independently at college and is seeking OCD treatment may or may not want or need their parents to be actively involved in their care. A 10-year-old who's living at home, their parents absolutely have to be an active part of treatment. They have to understand the things they do at home that actually enable OCD, how they can appropriately support their child, and what they need to do to help push their child appropriately. There's also a lot of providers who actively involve parents in treatment. There's protocols like the SPACE protocol developed by Eli Leibovitz that's focused on actually integrating and treating parents and teaching them how to appropriately treat their child's OCD. And so depending on the treatment intervention, parental involvement will be different depending on how involved the kids want to be, how ready they are to be active in treatment. But there should absolutely be a difference in the way parents are involved, which should be, they should be much more actively involved with children than they necessarily would be with adults. That doesn't mean with adults, parents aren't actively involved, significant others aren't actively involved, but it depends. I think it depends on what that adult with OCD needs. Let's hop over to live questions. how much ERP is too much? I want to get better quick, and I'm trying to do as much as possible. So, Augustina, I think this is a great question. I think my answer is that there's never too much ERP as long as we can do it successfully, right? If we're doing ERP 10 hours of the day, but we're ritualizing for 5 hours of that ERP a day because it's too much, or we're not ready for that level of intensity, that isn't going to be useful, right? It's kind of like if you work out in the gym, doing 100 squats incorrectly with incorrect form isn't useful, right? It puts you at a higher risk of getting hurt. It's not going to build muscles in the appropriate way versus doing a set of 25 squats appropriately and with the right form, because you can do that in a way that really makes sense and that's going to be useful. And I think ERP is a muscle much like that you build up, much like exercise. And I would say that, a lot of people choose residential support, PHP, higher levels of programming just because of what you mentioned, which is, hey, I'm struggling and I'd rather not have a long drawn out process to recovery. I want to get better as quick as I can. And so I don't think there's necessarily an amount of ERP that's too much, but I think that if ERP is being compromised, so if you are feeling burnt out, if you are doing ERP so much but not correctly, right, that's when it would be more important to address tapering it back. Do you know if there's any residential or IOP programs being offered virtually right now? Absolutely. So McLean's programs in Houston and in Boston have virtual programming if you live in those states. Rogers Memorial has virtual programming. I believe Neurobehavioral Institute has virtual programming. So almost all OCD programs right now. Residential, of course, is not virtual because residential in and of itself means that you would live on site. It would be a program where you're staying at the residence of the program, but most programs are doing IOP and even PHP levels of care virtually across the US. Thank you for your question, Michael. I'm coping well. I think that, always have ups and downs. I always continue to push and have active exposures I'm doing, and I'm very candid about that. But I'm pushing through. One of the things I said, I had therapy this morning and I was talking with my provider is like, I have an active exposure I'm doing right now, but despite that active exposure that is lingering a little bit for me, like I'm still living, right? I'm showing up to work, I'm doing these values-based things. And so for me, that's a huge win. Can you give some examples of what ERP looks like for false memory types of OCD and how to tackle the fear of false memories themselves? So I think, Mason, this is a wonderful question. And really, it looks just like other forms of OCD, right? It's all about the basis of OCD treatment, which is leaning into uncertainty. So when we have false memories or we can't remember something specifically and we're fixated on it, we're ruminating on it, we want to try to understand it all the way, we want to try to solve it, it's about not ruminating, right? So removing rituals. So not ruminating, not getting stuck, but also engaging in an exposure, which is leaning into the uncertainty, right? That may or may not happen, and I'll have to live with that. Or, maybe that's the case, maybe not, and I'm going to move on, right? Versus trying to solve it. Remember, anytime we're searching for certainty, we want to be sure, we want to understand, we want to know with positivity or with certainty, right? That's when we're feeding OCD. But overall, when we choose to lean in, we choose to be willing to feel uncertain, willing to feel uncomfortable, right? That's where we're fighting OCD. Ayelet, the best way to get a hold of us would be to go straight through IOCDF. So if you guys, you can, of course, send letters there or email them directly at info@iocdf.org. Great, Michelle. Yes, so we will absolutely do a level of care and maybe even a tour of what some of the programs look like. We could maybe have individuals from some of the main different programs. We could talk together and we could do a slideshow about what our programs look like, what to expect, right? So there's some programs like ours where we are more of kind of a boutique mental health clinic here in Houston. We're a smaller program with 11 residential beds. Each bedroom does have, well, I shouldn't say that, 5 out of our 6 bedrooms have double beds, so you could have a roommate, but they all have individual bathrooms in that room. So the most you'd be sharing a bathroom with is one individual, where some have group bathrooms, more kind of dormitory style. We all have different kind of ways that meals are served, that food is eaten, that laundry's done, that cleaning happens. And so I think it'd be great for us to think about the different programs and show that, because I think that'd be very useful. I think, so Raul, to answer any of your questions that could be around side effects from medications, I would encourage you to speak to a psychiatrist about this, about kind of what you're experiencing and what's going on. to see if there's any opportunities or if they would want to consider adjusting or addressing any medication. Michelle, when would I recommend residential support? You know, all residential support programs start with an intake. So you can't just call and show up, right? We want to do an intake. And so what I would say is if you feel like you may be at a place where a residential support program might make sense for you, right? And really this tends to be individuals with anxiety and OCD that it is impacting your functioning in various ways, and it is interfering in a major way in your life where you are, you know, you're saying like, I need to take a pause. I need to take a break and focus really solely on this. I need to spend some dedicated time addressing my OCD and anxiety so that I can get back to living. I think that if that's where you're at, you should absolutely consider it. And the first thing you would do is you would call a program, fill out some paperwork, and then schedule a phone assessment. And that phone assessment is done for them to be able to give feedback of if a residential support or residential program is the right fit for you, if it makes sense, and if it's something that they think would benefit you right now with your struggles and what you're going through. So you don't just show up and see if it works, right? There is a process, there is assessments, there is screenings to be able to determine if we think this will be the right fit for you and for the treatment, if this is the appropriate treatment kind of protocol that someone would recommend. Also, the second piece is that, you know, your outpatient provider should be a really good predictor. I'm at a loss for words about the right word to use here, but you guys know what I mean. But like, they should be a good person to kind of be able to say, this is what I'd recommend, right? Use them as information sourcing for you of what do you think I need? And do you think this would be a program I should consider at this time? Any OCD specialist, it is our job ethically to be very candid and clear if we don't think we're going to be able to move you forward in treatment at this level of care, and if we would recommend a higher level of care. Do you have advice for parents of a 20-year-old with OCD avoidance issues? She's really struggling to finish a few online high school courses. I think that, you know, really my biggest advice is support, right? We can't force an adult to do anything. We can't even treatment, right? We can know, like we might know that treatment or certain things would be really useful or really important for someone we love, but at the same time, especially when they're an adult, they have to want that. They have to agree with that. They have to make that choice. And so I think as a parent, the best thing you can do is work to support them. You know, hey, I see that you're struggling and I just want to know if there's anything we can do to help you with this. Are they actively engaging in treatment? Can you encourage that? Can that be something they would consider doing? So really working collaboratively with them to think about support that can set them up for success, right? Not sending the message that we don't think you can handle this, that we don't think that you're doing this right? That's not going to be useful, but instead the message of we love you, we care about you, and we don't want to see you struggling. How can we help? What do you think would be useful for you to help give you the best chance of success? How can one differentiate between OCD thoughts and thoughts that aren't? I'm having trouble with this and I don't want to blame everything for OCD. I think this is a wonderful question and something that I get all the time. And the short answer is like, I can't tell you right now, as not being your clinician, this is OCD, this isn't. But I think that the more you engage in active OCD treatment with an OCD specialist, the more you will be able to on your own know this is OCD or this isn't. So an example for this is that I was just speaking with my provider today talking about something that I'm feeling really anxious about and having an active exposure around currently. And her response was, is this normal anxiety or is this OCD? And I said, well, here's where the normal anxiety is, but here's where it's clearly OCD. And I'm able to differentiate that, right? I'm able to say like, yeah, there's some normal anxiety in this. Everyone has anxiety around it, but here's where my OCD has totally taken control, right? That like I have this disease and this is going to happen and there's going to be this terrible outcome and I need to be thinking about it. And then ruminating and staying up at night and trying to figure it out versus just kind of, I'm a little bit anxious. I want to, see what my blood results say if that's kind of what I'm waiting on. And so it's really about being able to on your own, after doing a lot of work and better understanding you and your OCD and anxiety, being able to differentiate. It's not something I can just say this isn't, right? Because even OCD, some patients will like a compulsion is that I want my provider to tell me if it's OCD or not, because then I feel better, and that's reassurance. So sometimes it's like, so is this an OCD thought? And sometimes knowing something's an OCD thought can make us feel better, but that actually can serve as a ritual. And we have to lean into like, it may or may not be, but what decision am I still going to make in my life, right? How am I still going to live a values-based life, whether this is an OCD thought or not, whether this is anxiety-driven or not? So I think really you would want to work together with your provider, but the more you engage in ERP and the more you have really good insight into your own OCD and when it feels like OCD, the better you'll understand. I think two things I use as thresholds are if there's this level of urgency. So if I feel like I have to solve this right now, I have to understand it, and it feels really urgent, pause, right? Don't try to solve it right away, because that may be when you're actually trying to answer OCD or trying to answer anxiety, but instead take a breather and kind of slowly address it. And then the second that I often will say is it about certainty, right? Is it something that I'm curious about, I'm trying to understand, or I'm trying to think about, or is it something that I need to be certain? I need to know for sure. I can't have uncertainty around this, so I need to fully understand it. I need to solve it. Oftentimes when things are rooted in trying to have total certainty, which isn't a realistic way that we can live our life, that can be OCD or anxiety driven. So I think it depends. You'll want to work with your provider. The more work you do, the more you'll understand it. But also kind of think about what is the driving force, what's the fear? And if it's anxiety and certainty based, maybe that's a way to kind of think about this. This could mean, for me, could be more OCD, it could not. Thank you guys so much for today. It's been a wonderful conversation. I love having so many questions in advance and live questions. And I hope that you'll continue to join me every other week so that we can continue to do this. So again, every other week I'll host my Live with Liz, where it'll look just like this. I'll be here to answer questions, give advice, give support, give feedback. And then on opposite weeks, I'm going to be doing my Lunch and Learn. As always, Ethan Smith will continue to moderate town halls. He'll continue to do just Ethan, and we will continue to work hard to bring you content that's valuable and useful to you. Please email us at info@iocdf.org for suggestions, thoughts, things that you think would be useful for us to cover and to talk about. I'm going to answer this last question from Ashley, and then I want to give some updates on upcoming events. I'm in regular therapy right now due to unavailability of finding an adequate OCD specialist. She's willing to help me do ERP, but wants me to build mindfulness skills first. She also wants to discuss patterns that cause my OCD. Worried this could make things worse. How do I determine if it's the right therapy? I don't have many options. I think the questions you're asking are really important, Ashley. I think they're really valuable. I think that oftentimes when it's a clear OCD diagnosis, mindfulness can be useful, can be helpful, but really we need to be doing ERP. Spending a lot of time understanding, like, why might you be having these thoughts? What could cause them? We don't find that to be that useful when it comes to specific OCD treatment and OCD symptoms, if that's what you're dealing with. I would encourage you, Ashley, to visit iocdf.org and see if there's any specialists you might be able to work with. I would also push that right now, a lot of COVID-related accessibility, COVID has increased accessibility. So there's been some restrictions on state licensing. So there's a lot of providers who are able to practice in different states because they get their license there. They have a provisional license. And then also No OCD. So In OCD is a wonderful app that has clinicians across the globe that at least have some basics and understanding in ERP, and that should be able to have much more specialized OCD training than a general practitioner. So I would certainly recommend that app as well. But I think overall, Ashley, I'm proud of you. These questions that you're asking are important. And I think I would want to know the same things, right? Like if I'm here for OCD treatment, I need to do OCD treatment and ERP. Spending time trying to understand where these thoughts come from, or doing some other stuff isn't going to be that useful if it's really time and I need to actively engage in ERP. Jennifer, if you want to share your experiences, there are so many wonderful opportunities. And sorry, I'm just seeing your other message as well about starting support groups and writing ideas. Please go to iocdf.org and peaceofmind.com. There's some wonderful tools and tips about how to start support groups, how to get actively involved. At IOCDF, we have grassroots advocates where you can join a community of advocates who work together to do work in their local areas. Definitely make sure you attend our conference if you can, which is held every year in July. Of course, it was virtually last year, and we'll kind of make steps to determine what it'll look like in 2021, but it's a wonderful way to connect. And there's large advocate communities, there's online support groups, and lots of ways that you can pour out and connect. Remember, advocacy doesn't look only like media, right? Advocacy can be about education, about using a social media platform. It can be about writing a blog. It can be about sharing a story, talking to teachers, increasing education in the schools that you went to. There's so many wonderful ways. So thank you all. Ashley, please reach out to us at iocdf.org so we can see if there might be any other options. I am so grateful for such a wonderful community and wonderful conversations. I love spending time with you guys and feel invigorated every time I do and extremely inspired. Some upcoming town halls. Tomorrow, Ethan Smith will be leading an upcoming town hall at 7 p.m. Eastern time on OCD and substance use. This will be so important and a topic that I think is just critical that we're really talking about and bringing light and awareness to. We'll have some amazing special guests. At 7 p.m. on next week, so November the 17th at 7 p.m., Ethan's going to be doing a Just Ethan, but this is going to be focused on a film edition. So he's going to be talking with Gabe Wilson and bringing a guest on to talk about film and talk about OCD as always. Next Wednesday, I'll be doing a Lunch and Learn. My Lunch and Learn next Wednesday will be at 3 p.m. Eastern time, and we're going to focus on OCD and hoarding disorder in adults. I think for those of you that have family members or a loved one who have OCD and also have hoarding disorder or hoarding tendencies, this will be a really important, amazing talk for us to bring light and awareness to how treatment looks different and what it might look like for this arena. Again, tomorrow, OCD and substance use, the film edition next week, our Lunch and Learn on hoarding disorders will be next week as well. I love you all. I'm grateful for this community, and I can't wait to see you guys soon. Take care.